Hi, my name is Ali Hussein, and I'm going to be talking about the blood response to vascular implants. Examining the blood as it flows across the healthy blood vessel wall, we will notice that the endothelial cells that line the blood vessels employ a number of strategies to maintain the uninterrupted laminar flow of blood. One of these strategies is the glycocalyx, which is a hydrogel right at the interface between the blood and the endothelial cells. And it's composed of sugars and proteins that are attached to the cytoskeleton of the endothelial cells via transmembrane glycoproteins. And this hydrogel right at the interface is very important because it has the ability to translate the mechanical signals of the blood flow, informing the endothelial cells how to modulate their behavior. It has the ability to dampen the shear stress that's experienced by the blood, and it also sequesters certain antithrombotic molecules. For example, heparan sulfate that's in the glycocalyx sequesters antithrombin, which is a potent inhibitor of thrombosis. So you can come to realize that the glycocalyx is a hydrogel physical surface that prevents thrombosis. Another strategy is that the endothelial cells are continuously secreting various molecules that actively prevent thrombosis. Those molecules also have an influence on the smooth muscle cells that are residing under the subendothelial collagen and above the fibroblasts. So we will see the big picture that the blood vessel wall stage is really composed of the hydrogel physical surface and the chemical and biological nature of the molecules that are secreted, which are vital for maintaining the normal laminar flow of blood. Which leads us to the question, what are the actors in the blood that are so sensitive to this blood vessel wall stage? And to do that, we need to take the blood and centrifuge it. And you'll see that around 55% is the plasma, which is composed of the water, proteins, and all of the other solutes. About 1% is your white buffy coat, which is your platelets and the white blood cells, and the remaining are the red blood cells. So what I'm going to do today is take you on a biological journey to really examine what are the actors in the blood that are so sensitive to the disruption of this blood vessel wall stage that is irreplaceable. So let's imagine we implant a vascular device, and what immediately happens is injury. We have disrupted the glycocalyx, we have injured the endothelial cells and exposed the subendothelial collagen. The stars that you see on the screen, those are indicating damage or danger signals where the endothelial cells or the collagen is telling the blood, we've just experienced trauma. And you can imagine that we've lost the blood vessel wall stage and it's being replaced by an implant stage, which affects the normal laminar flow to become abnormal and non-laminar. And we will actually look at how the water and proteins behave in this new environment with a new implant stage. Let's imagine we magnify the blood. What we would be able to see is the proteins and the water molecules. And you would see that the proteins are those long chains of amino acids that wrap around and form a shape. And there's a protective shell of water molecules around them that help solubilize them. Now, at the implant stage where the glycocalyx used to reside, now you have a new implant stage that has different properties, such as chemical or physical properties. And what that does is it prescribes a certain order to the water molecules that interface with that surface. And right adjacent to that, you would have disordered water molecules in the bulk phase. And if you remember thermodynamically, the universe hates order. So we would see how the proteins come and disrupt this order. To do that, you need to look closely to the proteins. You would see that they have some amino acids that love water molecules, some amino acids that hate water molecules. And if you can imagine proteins being long chains of amino acids, some of which love water molecules, some of which that hate water molecules, as they wrap around, they will guard those amino acids that hate water molecules on the inside and expose those amino acids that love water molecules on the outside. This maintains a water shell around it that helps solubilize it. You also have to keep in mind that some amino acids are positively charged while others are negatively charged. And that's tightly regulated by the pH of the environment. So at the isoelectric point or pH, there is equal number of positive and negative charges on the protein. So there's a net zero charge. And you can imagine as you go down in pH, you become more positive. As you go back to the isoelectric point, you again get a net zero. And if you go above the isoelectric point, you have a net negative charge. Most of the proteins in the blood are negatively charged because they have an isoelectric point below the pH of the blood, which is about 7.3 to 7.45. So now you can imagine that the protein has an army of amino acids with different properties to absorb and bind to the surface. So let's say if the surface loves water, the protein will use its water-loving amino acids to basically displace the water molecules. Let's say if the surface has water-hating properties, then the protein will use its water-hating amino acids to attack the surface. Similarly, if the implant stage is positively charged or negatively charged, there are a number of amino acids that the protein can use to basically absorb and bind onto the implant stage. So by now you can appreciate no matter what the implant stage surface is, if it's water loving, water hating, negatively charged or positively charged, the proteins will find a way to absorb onto the implant surface and they will displace the water molecules. And this initial absorption might be weak and reversible because the proteins have to change their shape and find their most thermodynamically stable composition or shape for it to form a good bond with the surface. Now remember, the blood has hundreds of proteins. Some of them are small, some of them are large. So imagine a larger protein that comes along that has more binding sites. So it will be easy for us to see now how that larger protein will displace the smaller protein, change its shape, unravel, and form stronger adsorption bonds onto the implant surface. This table provides a snapshot. There are hundreds of proteins in the blood, and you can see that depending on the molecular weight, depending on the concentration, and the isoelectric point, you'll have different diffusion coefficients that will affect the adsorption of the protein onto the implant stage. And what's important is that due to their adsorption and change in shape or orientation, you will get exposure of signaling sites that were previously hidden but now are available to induce certain cascades into the body. Another mechanism by which proteins could get activated or denatured by the implant stage is through shearing. So let's imagine we have a globular protein that flows past the implant stage. So it mechanically deforms and unravels, exposing those signaling sites. This is very prominent in the von Willebrand factor proteins that unravel to form nets that catch onto the platelets. So if you remember, we were talking about the protein actors, and now we'll move on to talk about the platelets and the other actors that would get activated by the implant stage. At this point of our journey, we will get to see how those proteins that have been adsorbed or shear activated influence other actors in the blood to promote certain cascades, for example, the platelets, white blood cells, and other proteins. Conceptually, we will think of those cascades as four separate ones, but please appreciate that in the body, there is significant crosstalk and feedback that blurs the lines between them. So if we look at the coagulation cascade, it's basically a series of protein complexes that work on one another to generate thrombin. Thrombin in turn accelerates the conversion of fibrinogen into fibrin, and fibrin is basically long protein chains that can be cross-linked to form a three-dimensional matrix of insoluble proteins. You have to appreciate that we started from soluble proteins and now we have a network of three-dimensional cross-linked insoluble proteins that is designed to slow things down to facilitate other cascades. If we look at the platelet cascades, platelets are cytoplasmic remnants, so they're not really cells, but they're small portions of cells, and they can get activated by shear or through the adsorption of certain proteins on the implant stage, and they change their shape to form stars that can basically pack just like a jigsaw puzzle, and they can secrete certain signaling molecules that activate themselves and the platelets around them. So you can start to see that the adhesion, activation, and the aggregation of platelets really changes the surface of the implant stage. Now, keep in mind, in the clinical setting, usually the patient is loaded with dual antiplatelet therapy to minimize the risk of a thrombosis. But we're talking at the surface where the platelets will form a new stage where the other cascades can proceed. You also have to keep in mind that thrombin itself can activate platelets because they have a receptor for it, and platelets can secrete proteins which are part of the complexes that are necessary to generate thrombin. So you see the crosstalk between the two cascades. Next is the complement cascade. Complements are basically a series of around 30 proteins that are secreted by the liver. They're continuously surveilling the body for abnormal signals. And when they find it, they start to adsorb, just as they adsorb onto the implant stage. They induce certain cascades that can recruit first responder leukocytes. Those are your white blood cells or your inflammation cells that sets the stage for the cellular response moving forward. So conceptually, we can categorize this cascade as the recruitment of first responder leukocytes, which is then followed by the aggregation between the platelets and the leukocytes because they can bind, and the leukocyte starts secreting certain inflammation signals that will dictate or define the course of action moving forward. So the last cascade is really the leukocyte cascade, and we'll look at that in the next step, where we see how those cells will try to modulate how the cellular response to the implant stage would be. So taking a step back, we'll see that we have modified the implant stage with activated platelets that secreted a number of signaling molecules, and then we have superimposed on those platelets a network of three-dimensional insoluble fibers. And then we have leukocytes or inflammation cells that are secreting signals that will define the cellular response moving forward. One more thing that to keep in mind, remember how we damaged our cell lining of the blood vessels? So those danger signals from the endothelial cells or the subendothelial collagen can themselves activate those cascades. So you get to appreciate the complexity of the signaling system and the crosstalk between them that orchestrates this very cohesive response. At this point of our journey, we will shed some light on how the leukocytes get to define the cellular response and the healing of the body to this implant surface. So we got to the point where the leukocytes have adhered onto the fibronectin or the fibrinogen or the complement or that bioactive cascade of events that happened on the surface, and the leukocytes in response to that will start secreting certain signaling molecules that will behave as an input for different cell types that will dictate what kind of macrophages they will differentiate to, and depending on the selection, those macrophages in turn will secrete a certain family of signaling molecules that will dictate what kind of response will happen moving forward, whether it's pro-inflammatory to invite more inflammation cells, whether it's tissue repair, whether it's fibrosis or the secretion of more matrix protein. Basically, the leukocytes and the inflammation cells set the stage, and the matrix try to replace that precious endothelial cell lining that we disrupted when we first implanted the device. Thank you for listening.